Good afternoon, everyone, and happy Thursday. I'm Karina Hill, and on behalf of the Florida Alcohol and Drug Abuse Association, we want to welcome you to today's webinar entitled Understanding and Treating Patients with Opioid Use Disorders and Comorbid Pain Issues. And this presentation will be given by Dr. Melanie Rosenblatt. This webinar is being made available through a collaboration of the Office of the State Courts Administrator and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me by using the Q&A panel or the chat box. The button to open the panel is usually located on the upper right side of your monitor. You may also use the Q&A panel to send any questions you may have as you think of them, and the presenter will address the questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options are posted in the chat panel too. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 30 business days. One helpful hint is the archived video displays what looks like to be an error message, but it's only a delay buffer, so you want to just ignore it, hit play, and enjoy. To access the recording of PowerPoint, you will go to www.fada.org at the Resource Center in our training library. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families and the Office of the State Courts Administrator. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign in to your account to complete the evaluation. So you must have completed a profile within our website to complete the evaluation. Information you provide FADA as part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Do note that the evaluation will close at midnight on Monday, June the 8th. So in approximately 30 days after June the 8th, you will receive your credits or CEUs in your account. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your certification number when you register with our site. Note, please, and this is very important, that WebEx does monitor your arrival and departure, and it provides a report to us upon completion of the event. So you must attend the entire event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. And with that being said, I would like to introduce our presenter, Dr. Melanie Rosenblatt. She is a graduate of the State University of New York at Stony Brook School of Medicine. She completed her anesthesia residency and pain training at St. Joseph's Hospital Healthcare Center in Syracuse, New York. She is board certified in addiction medicine, pain management, and anesthesiology. She has been practicing in South Florida since 1995 and maintains her practice in Boca Raton and Deerfield Beach, Florida. Melanie Rosenblatt was the medical director of pain management for Broward Health North, a level 2 trauma center from 2002 to 2017, where she was the chairperson of the Credentials and Qualifications Committee and sat on the Medical Executive Committee board. She has worked with the U.S. Drug Enforcement Administration and local law enforcement to crack down on pill mills in South Florida. She has served on the advisory board of several pharmaceutical companies that were developing abuse deterrent formulations of opioid medication, and she lectures nationally about safety and risk assessment in the treatment of chronic pain. Dr. Rosenblatt has worked with legislative bodies to help address prescription pain medication abuse and was on the medical and wellness team at Newsmax Health. She was featured in the 1-hour 2018 documentary Pain Matters by the Discovery Channel. Dr. Rosenblatt is a recognized thought teacher or leader and national expert in her field and consults for both federal agencies and several private companies. And now I would like to welcome our presenter. And Dr. Rosenblatt, if you are ready, I will turn the presentation over to you.
Good afternoon. Thank you, Karina, for that warm introduction. And hello, everybody. I'm excited to be here on this rainy Florida afternoon, staying in like most of us. And it was a good day to do a rainy online WebEx presentation. So thank you for having me. Karina, I'm not seeing my slides. I'm still seeing the last slide you had up, which is a picture of me.
Okay, let's try this again. I'm going to pass it back and forth. Okay, do you see them now?
No, I still see me.
Let's try this one more time.
Oh, there it is. These look familiar.
Okay. Sorry about that.
So we've got plenty of time to go through a fair number of slides, but I think they capture the essence of what we're here to discuss. And I'm also happy to take questions as we go along. I'm able to see the chat box on the side, and I'll do my best to get to all of your questions as we go along. A little bit more about me. I am in private practice. I treat pain and addiction all day long, and I find the interplay between the two a fascinating space, that addiction specialists seem to not treat pain patients and keep them in a separate bucket, and pain specialists tend to not treat addiction patients and keep them in a separate bucket. And I think where the two interplay is fascinating, and I have some very interesting data to show you and some very, very cool science. This is my conflict of interest. You've already heard about who I am and what I do. There's really no conflict specific for today's presentation. At the completion of this webinar, our participants will be able to be familiar with the current trends regarding the population impacted by addiction and co-occurring disorders in the U.S., become familiar with the opioid overdose epidemic and the occurrence of comorbid pain issues with those suffering from opioid use disorders, be able to identify pain management strategies for individuals with pain who are currently engaged in illicit substance use and beginning treatment, and increase understanding of strategies to treat both acute and chronic pain in individuals with an opioid use disorder who are also receiving medication-assisted treatment, and to describe the challenges in acute and chronic pain management with strategies for utilizing various MAT medications to treat opioid use disorders. These statistics all come from SAMHSA's website. In 2018, there were 165 million people aged 12 or older in the U.S. who were past month substance users, including tobacco, alcohol, and illicit drugs. 140 million of Americans aged 12 or older were past month alcohol users, and 19.4% of people aged 12 or older had used an illicit drug in the past year. Prescription pain reliever misuse was the second most common form of illicit drug use, with 3% of the population, or approximately 1.7 million people with prescription pain reliever use disorder. 20.3 million people aged 12 or older had substance use disorder, 2 million people had opioid use disorder, and 9 million adults age 18 or older had co-occurring any mental illness and substance use disorder. The opioid overdose epidemic in the United States, some of the statistics in 2013, accidental drug overdose surpassed motor vehicle crashes as a leading cause of death. In 2014, there were over 47,000 drug overdose deaths, 26,000 of which were opioid overdoses. In 2017, over 70,000 Americans died from drug overdoses. Over 47,000 of those overdose deaths were from opioids, and 17,000 of those overdose deaths were from prescription opioids. Over 28,000 overdose deaths were related to fentanyl and fentanyl analogs. And in 2019, 69,000 overdose deaths, 7 out of 10 were due to opioids. So in total, over 770,000 Americans have died from drug overdoses since 1999, and there are approximately 2 million people in the U.S. suffering from opioid use disorders. The national rate per 100,000 population opioid-related healthcare visits, the blue line shows the inpatient and the green line shows the ER visits. There's been, you can see a rising trend in visits for opioid-related issues. And this has been described as a multi-layered problem in 3 distinct waves. In the 1990s, that sort of marks the rise in prescription opioid overdose deaths, and there's a lot of people who believe that Big Pharma had a lot to do with that. A lot of people believe that JACO and pain is the 5th vital sign had a lot to do with that. A lot of people think the HCAP scores had a lot to do with that. A lot of things came into play. But in the 1990s is when we started to see a marked rise in prescription opioid overdose deaths. In 2010, we saw a big spike in the rise of heroin overdose deaths. And in 2013, we see a rise of synthetic opioid overdose deaths, such as fentanyl and tramadol. There are many factors that determine what a substance use disorder is, but it is a cluster of symptoms reflecting a continued pattern of use despite accumulating consequences and problems that come from alcohol or other drugs. So it's the cluster of cognitive symptoms, behavioral symptoms, and physical symptoms that contribute to the problems. Now, the problematic pattern is broken down into 4 areas, and there are symptoms across each of the areas, and this is how we actually try to quantify the opioid use disorder. So the 4 areas are impaired control, social impairment, risky use, and pharmacologic, and underneath each of those categories are some of the symptoms. And 2 to 3 symptoms across these 4 areas are how we measure the severity of opioid use disorder. So under impaired control, what we'll find is people may take increasing amounts over time, which is a little separate from tolerance, but rather increasing their use over time because they can't control it. They continue to fail when they try to cut down. They spend more and more of their free time spent in trying to obtain the drug, trying to recover the drug, using the drug, and they crave the drug. The social impairment symptoms are they fail to fulfill obligations at work and school and home. They continue to use despite harm, despite repeated social and personal problems, and they give up social occupational or recreational functions in order to use their drug. Under risk use, they continue to put themselves in harm's way in hazardous situations, and they continue to use despite an awareness of physical or psychological problems caused by the substance use. And pharmacologic, this is new to the DSM-5, but it's in there now that if you display tolerance or withdrawal, that is one of the significant symptoms for opioid use disorder. So the severity of substance use disorder or opioid use disorder is graded as mild, moderate, or severe depending on how many of those clusters of symptoms you have. Now, for each substance, such as alcohol or marijuana or opioids, they would be each separately graded. So you can have a mild opioid use disorder and a severe alcohol use disorder concomitantly. Some specific terms of recovery from substance use disorder are early remission, sustained remission in a controlled environment on maintenance therapy. So people in early remission are, after full criteria for substance use disorder were met, none of the criteria were met for 3 months, or for less than a year, but at least for 3 months. And that does not include cravings or a strong desire to use. So people in early remission are off to a good start. They've been they had symptoms of the substance use disorder, but none of those criteria are met from 3 months to 12 months. In sustained remission is the same, but during a 12-month period. So they have, except for cravings and except for strong desire to use, they have been in full remission for 12 months, and that would mean they have none of the criteria met for substance use disorder. In a controlled environment, these are people who are currently actively in a treatment center or in a halfway house, in a transitional program, or sometimes incarcerated. And for those people on maintenance therapy, we'll talk about medication-assisted treatment a little later in this presentation. Medications can be very effective in blocking or eliminating their drug of choice. This is the DSM-5 criteria. I won't go through this again, but this is the same. And you can see number 10, tolerance, is there, and 11, withdrawal, is there, and then the mild, moderate, severe opioid use disorder, and then the early remission, sustained remission, controlled environment on MAT. The brain disease model is controversial and very important. And for me, when I first began to understand this, it was a real game changer for me. So many people place blame on the person who is using substances. But when I first came across the brain disease model, it helped me understand addiction more as a chronic illness. And when I describe it to my patients, I describe it much in the way of other chronic illness such as hypertension or diabetes. And our hypertensive patients all remain on high blood pressure medicine, much like our diabetics remain on insulin medication, until something significant changes. Perhaps it's a better lifestyle, weight loss, better eating, getting exercise, whatever it may be. It's a chronic illness for a long period of time. So animal and human studies have shown that critical brain structures and behaviors are disrupted by chronic exposure to drugs and alcohol. And the brain disease model helps to explain how drugs and alcohol impact brain processes associated with loss of control, compulsive drug use, inflexible behavior, and negative emotional states associated with addiction. Understanding these processes has already resulted in several effective medicines, as well as new and promising medication targeted to treat drug and alcohol addiction. Additionally, a disease framework has also led to the development of promising brain stimulation treatments and behavioral interventions. So addiction is a complex disease of a complex brain, and ignoring this fact will only hamper our efforts to find effective solutions through a comprehensive and systematic understanding of the underlying phenomenon. Advances in neurobiology have begun to clarify the mechanisms underlying the profound disruptions in decision-making ability and emotional balance displayed by people with addiction. These advances also provide insight into the way in which fundamental biological processes, when disrupted, can alter voluntary behavioral control, not just in drug addiction, but in other related areas such as self-regulation, such as obesity, pathological gambling, video gaming, these so-called behavioral addictions. A more complex understanding of the brain disease model of addiction may help to moderate some of the moral judgment attached to addictive behaviors and foster more scientific and public health-oriented approaches to prevention and treatment. The brain regions impacted by drug use, this might get a little sciencey for some of us, but it's important that you hear this. Basal ganglia, the extended amygdala, and the prefrontal cortex are all very important brain regions that are impacted by drug use. The brain reward system is involved in the cerebral cortex, the hippocampus, the amygdala, and the nucleus accumbens. I know you've seen these names before, and there'll be even more information about these in our upcoming slides. I put the slide in there just to remind us all of what exactly we're talking about. A lot of people in classrooms will learn about drug use, or in certain environments will hear about drug use and all kinds of problems. But on the healthcare, on the medical side, and these are actually real photos that I took in my consultations in the hospital. So these are patients who are admitted to an acute medical facility with medical problems, came through the emergency room. They each have their own story. But drug use was not necessarily suspected or understood through all these people. These three individuals, none of these were their first hospital admission. And so the system would perpetuate bringing them back into the hospital, like I showed you that slide of increased ED and increased hospital visits. This is pretty typical of what I would see. So the first slide on the left is an individual who is injecting into his hand. As was the last slide, is somebody injecting into their foot, which is a reminder when you're looking for track marks on patients, look beyond the obvious areas of the upper extremities. The first slide, by the way, the one of the hand, that patient said that there was a spider bite. The picture in the middle is one of my favorite because it's one I don't typically see. On these lectures all the time, I see pictures of IV drug use and I see pictures of track marks, but I never saw this. So those of you who think I just put a fork on top of their belly and took this x-ray are wrong. This is a picture of a patient who swallowed a fork and said to us on this admission, "Ha, now you have to give me drugs." And I just thought that was so sad. So that's why that's in here. So GI consult, general surgery, exploratory laparotomy, sick person, a sick girl, and she had also multiple psychiatric admissions, but she couldn't be in the psych facility for this because she was so acutely sick. She was Baker acted at the hospital, and she was transferred to a facility after her discharge. 19 million people needed treatment for opioid use disorder, but did not receive any specialty substance use treatment. Over 20 million people over 12 or older needed substance abuse treatment, and only 3.7 million received any form of substance abuse treatment. And almost 1 million of those people felt they needed treatment and either made or didn't make an effort to get treatment, but the 18 million people did not feel they needed treatment, which is very typical of the people that I meet in the hospital. They don't think they need treatment for a substance use disorder. They just need what they need. This slide is up here to remind us of the broad levels of care, and within the 0 through 5 levels of care, there are gradations of intensity of services. So there's early intervention, there's outpatient services. So early intervention is where I often step in on like those slides that I showed you on the acute care setting. And then we have outpatient services, which I do have an outpatient treatment program. I do provide outpatient services. Then there is intensive outpatient and partial hospital services, or PHP. And then there's residential or inpatient services and medically managed intensive inpatient services. What is MAT? I assume most of you know about this, but there might be a few that don't. MAT is medication-assisted treatment. Very simply put, it is treatment that includes an FDA-approved medication combined with counseling and psychosocial support. And it includes outpatient treatment programs. It combines behavioral therapy and medications to treat substance use disorder. There are 3 approved medications for treatment of opioid use disorder. They are methadone, buprenorphine or Suboxone, and naltrexone. They are currently approved by the FDA, and when combined with psychosocial interventions, these medications help people recover. Medications to treat addiction involving opioid use are greatly underutilized, even though their use is so strongly associated with reduced morbidity, reduced mortality, and reduced costs. They're still undertreated. Less than 20% of patients with an addiction to opioids receive any treatment at all, and only 30% of treatment programs offer MAT program services. So I talk to my ER staff frequently about identifying withdrawal among patients. Most of the staff I know are pretty good at identifying intoxication. You can tell when somebody's drunk or abusing opioids based on their change in behavior. They're acting, stoned or lethargic. They have pinpoint pupils, slurred speech. You can tell when somebody's intoxicated. I find withdrawals a little bit harder to teach, and withdrawals a little bit harder to recognize. And we see many frequent admissions to the hospital for withdrawal that presents as nausea, vomiting, abdominal pain. They get a GI workup, they get a colonoscopy, they get endless CAT scans of their abdomen, they get a full-on negative workup. But as soon as they get IV Dilaudid or whatever the doctors treating them might give them, they tend to improve. And that improvement is based on receiving the agonist therapy that stops their withdrawal, whether it's in the form of IV Dilaudid or a PO Percocet, or they get their methadone dose. But the symptoms of opioid withdrawal, I like to teach by saying, think it's the worst flu of your life and everything leaks. So the symptoms are body aches, diarrhea, increased heart rate, yawning, nausea, vomiting, nervousness, restlessness, fever, irritability, runny nose, shivering or shaking, trembling, sneezing, stomach cramping, goosebumps, sweating, weakness, and increased blood pressure. And once you start putting that in your mind, and remember the flu-like symptoms and everything leaks, and you'll get every question you ever asked about this right. So everything leaks. Again, your nose is running, your eyes are tearing, you have diarrhea, you're sweating. To me, that becomes a very visual thing. And the way we can actually clinically measure this is with the Clinical Opioid Withdrawal Scale, better known as the COWS. So people get a COWS score based on the symptoms in the little yellow box, and each area is graded from 0 to 4. And then on the total score, you're either in mild, moderate, or severe withdrawal. And the symptoms up there are pupil size, yawning, bone or joint aches. And some of these symptoms you can see and some you have to ask, like GI discomfort. But it's interesting to watch them when they might yawn and how restless they are and how anxious they appear. And the other symptoms you'll just ask them about. So when we do identify this, what are the next steps? Well, depending on the clinical situation, getting a social worker or case manager involved for a referral to substance use treatment or whatever the appropriate level of care may be. To encourage follow-up for the patient, to follow up with the specialist, with the referrals for substance use treatment or with someone like me. When appropriate, they can have MAT services begun. Even I like to begin them in the hospital, which is where I meet most of these people, or when they come into my office in withdrawal, I will begin them with MAT services for opioid use disorder. I use a lot of buprenorphine. We'll talk about that in a minute. There was a randomized clinical trial I like to refer to. This is pretty well known at this point, where in an emergency department, they fell into 3 groups: people who came in with substance use disorder, opioid use disorder, in various stages of intoxication or withdrawal. They were split into 3 groups. One group, they initiated buprenorphine, naloxone treatment for opioid dependence. And the ED-initiated group was with either, one of 3 groups: the buprenorphine treatment, or 2, the brief intervention, and 3, a referral. And they found that all of them increased engagement in addiction treatment, reduced self-reported illicit opioid use, and decreased use of inpatient addiction treatment services. But it was the buprenorphine group that had the largest impressive numbers, and that was 78% of the buprenorphine group versus 37% in the referral group and 45% in the brief intervention group were engaged in addiction treatment on the 30th day after a randomization. The buprenorphine group reduced the number of days of illicit opioid use per week from 5.4 days to 0.9 days versus reduction from 5.4 to 2.3 days in the referral group, and a reduction from 5.6 to 2.4 days in the brief intervention group. So now I'd like to put out there a case study. This is a very typical patient, perhaps one would encounter in a family practice clinic. And I'm going to ask you some questions about this case study, so pay attention. This is a 35-year-old female with chronic daily migraine and diffuse myofascial pain who has been prescribed opioids for 5 years after the birth of her daughter. She has severe depression and anxiety, chronic nausea, history of adverse childhood experience, neglect as a child, and obesity. She is a stay-at-home mom to her 2 children, but frequently has to put the children in daycare because she cannot care for them when she has severe migraines. She is also prescribed chronic high-dose benzodiazepines by a psychiatrist. The patient has a history of losing her opioid prescriptions, obtaining opioids from another provider, being allergic to most other pain medication options, missing appointments, and frequently asking for opioid dose increases. So some questions I would like to put out to you, and I would like your participation in this, is 1, does this patient have pain? And you should see a chat box on your right of your screen that you can start to answer. I'm going to give some time and see how many of you are paying attention. Does this patient have pain? Okay, and does this patient have an opioid use disorder? What factors place this patient at risk for an opioid use disorder? And you can check more than one. And what can you do to help this patient?
Dr. Rosenblatt, I just wanted to clarify for the 4th question, you would need to answer that one in the chat box because it's open-ended. Thank you.
Karina, can I see these answers yet or not yet? We'll see them at the end?
Poll will close in about 30 seconds and they will be up.
Okay, are people answering them? Can you see
Yeah,
it?
we have,
okay.
Yeah, people are answering.
Okay, I can't see the answers. Okay. I'll give you all about another 30 seconds and then we'll move on. And maybe you want me to go back to the question. You can reread that if you like.
Fifteen seconds left. Okay, you should be able to see those results now.
Okay, let's see what that looks like. Okay, does this patient have pain? 76 people responded yes, 9 people responded no, 90 people didn't answer. Okay. Does this patient have an opioid use disorder? 77 responded yes, 4 responded no, 95 have no answer. And what factors place this patient at risk for an opioid use disorder? All over the place. Pretty much everybody got a check mark. Personality traits, young age of opioid use, use with benzos, mental illness, adverse childhood history. Okay, I like that. And what can you do to help this patient? Let's see, what have I got here? Suggest family and individual therapy. That's good, excellent. Also slowly step down dosing, possibly. And suggest MAT. I love that. Somebody else said MAT will help treat multidisciplinary approach for dual diagnosis. Okay, MAT. I'm seeing a lot of MAT. Okay, excellent. So we're going to go through some of these. First, I want to talk about pain, and this is very important to me. Persistent pain, and you already know I'm a chronic pain specialist. Despite the cause, whether it's low back pain, migraines, fibromyalgia, despite the cause, when pain persists, it often causes secondary problems that lead to a constellation of symptoms. They have sleep disturbance, they have cognitive distortions, they have increased stressors and stresses. They may have anxiety, depression, PTSD, secondary physical problems. They may have functional disabilities in work, in relationships, in their social life, and they may have substance use and substance misuse. And what I find fascinating is, as a chronic condition, opioid use disorder shares some similar challenges as persistent pain. And this is the same constellation of symptoms surrounding opioid use disorder. And I told you at the beginning of this presentation, where I live is where the two intersect. And so intersecting those looks like this. When opioid use disorder and pain co-occur, they can reinforce one another. So in order to successfully treat pain, you have to treat opioid use disorder. And in order to successfully treat opioid use disorder in a patient with pain, you also have to address the pain. And there's no other way around that. So it's complicated, and it's fun, and it's where I live. So we're going to talk a little bit when we come back after the break about what is the underlying neurobiologic mechanism that explains this complex interaction between pain and opioid use disorder. We're going to have some real sciencey slides. We're going to get back to that nucleus accumbens and amygdala as promised. But first, we're going to take a short break, and then we'll get back to it. And before the break, I'd like to open this up to some questions. I see some more comments on the answer to what could we do for our case study patient. And I'm seeing a lot of comments about MAT, therapy, individual therapy, counsel her on her children's risk. That's important as well. I'm looking for any more questions. And if not, Karina, I think we can take a quick break. I'll come back a little early from the break to get any more questions that people may come up with, and then we will resume.
Okay, so we're going to take about a 5-minute break. If you could be back by 1:45, that would be great. Thank you. Hello, I'd like to welcome everyone back from break. And I did want to let you know that whenever you're responding in the chat box, it's important that you select host and presenter or all panelists so that the presenter and myself both get the responses. What I'm noticing in the last question is there was a lot of great feedback, but it only went to me. So I'm going to read those comments real quick if you don't mind, Dr. Rosenblatt. For your last question, some of the comments were coordinate with primary doctor regarding cause of migraines, and if they began before she began the migraines, discuss alternative options with her for using opioids like MAT. As well, discuss withdrawal, investigate if she is open to making some changes in her treatment, psychoeducation, engagement, motivational interviewing, coordination with psychiatrists, let's see, tolerance, discuss alternative non-addictive medications, an eval with a psychiatrist. This patient could benefit from an MAT program with psychosocial support, neurological exam for migraines, and would it not be first important to check for withdrawal? That was a question. Psychosocial rehabilitation. I think readiness to change plays a huge part in which type of treatment is required for each individual. How do we bridge the gap that occurs often when individuals do not have their basic needs met, such as housing? Did you want to stop right there and I can continue with the questions? I didn't want you to forget the two I just mentioned. Dr. Rosenblatt?
Yes, can you hear me?
Okay, I can hear you now.
Are there more questions? Because I can't see them.
Yeah, there's more. And again, I wanted to reiterate to everyone, when you're responding, the presenter does not see your response if you send it to host privately. That just goes straight to me. So you either want to select host and presenter or all panelists when you respond. So let's see. The first question. Would it not be first important to check for withdrawal?
Absolutely, first thing to check for would be withdrawal. But I think from this case study, it's really very typical of what the primary care doctors will see in all the chart reviews I do for the DEA and the FBI and on the private side and for the DOJ are mostly patients just like this that come in and say, hey, doc, you're the best. I'm just here for my monthly refill of my hydrocodone. I need, 3 or 4 a day for my chronic migraines. Otherwise, I'm fine. And then in our case study, you saw that she wasn't exactly fine. And I've had physicians push back and say things like, well, we've tried other things. We can't find a source for her migraines. I guess we're just stuck on this because nothing else works. We tried Elavil and some other things, and nothing else worked. So I guess we're just kind of stuck with this. And she loses her medicines once in a while, but it's understandable. She's busy and she's got kids, and some days her headaches get so bad that she can't manage her family. There's just a lot of a limited understanding of addiction. And so one of the things I like to try to focus on is once you understand addiction, and I always have my addiction hat on, but once you begin to consider that as an option, sometimes things become clearer. Like there's no amount of alternative to opioid that's going to satisfy somebody who's seeking opioids. So it doesn't matter what you try. I see one question here about what about Wellbutrin and gabapentin, Topamax. Assuming she tried all those, they're also not going to work for somebody who actually is in the office expecting, wanting, demanding a prescription. And for example, in my practice, I see people all the time. I saw 4 new patients today. Offhand, I can't remember them all, but just this morning. One of them was insistent on her doctor doesn't believe in writing opioids and only gave her epidurals and wanted to do surgery. And she doesn't want surgery, and the epidurals made her worse. So she's coming to see me clearly just for opioids. I said to somebody the other day, so you actually don't really care what I think. You're just here for the Percocet or whatever it was that she wanted. She's like, yeah, that's right. I'm just here for the Percocet. And it just fascinates me how people can be so motivated to just get their drug. And again, we already went through in the first hour what opioid use disorder is and what symptoms are, count towards that. And once you can start to sort through that, it becomes a little clearer. Although I just had a primary care doctor on the West Coast in California say to me on a conference call yesterday, he said, but I'm not a detective. And this is a clinic that just does automatic refills, 336 Percocet a month automatically, and they miss some of the opportunities to help people that need help more so than just rewriting their controlled substances.
Okay. We had a question that says, is Vivitrol an MAT that is approved?
It is, and we're going to get into that in the second part of this presentation.
And then how do you bridge the gap that occurs often when individuals do not have their basic needs met, such as housing, but need therapy?
I would say in a situation like that, we would need to get social workers involved. There are placement services. I use a referral agency for that to help them get the housing, the perhaps residential treatment that they need. It's difficult to navigate that. I keep myself more in the role of a clinician, so I'm going to punt on that answer. But there are resources out there.
Okay, and then we have another question. Isn't it true that the body creates pain sites in the body where no injury has occurred for the body to prove there was pain? Fluorine scans reveal this through lit up pain sites. Thus, folks on long-term pain meds can become chronic pain sufferers just from the meds alone. Is this correct?
That's correct. It's called opioid-induced hyperalgesia.
Okay.
It's a hard sell. It's a very hard sell on my patients who come to me on high-dose opioid therapy that want to continue it, and I try to tell them that the way to make your pain better is to take away the pain medicine and, of course, treat the withdrawal simultaneously, and they don't believe that. They're not having it. They want to maintain their high-dose opioids. In some cases, in the thousands of milligrams a day, it can be really insane. I have a few questions here I can see. One is, what is gabapentin used for? Gabapentin is an anti-seizure medication, but we use it off-label for neuropathic pain. It's pretty effective, but be careful, it's also widely abused. A statement here, the patient in our case scenario, she may not even agree that she has an addiction. Absolutely, you're 100% right. She probably doesn't believe that she has an addiction. She probably believes that she has bad migraines and needs medication every day for it. I see a comment here, always one story after another. Yup. Same, I feel your pain. Education on addiction for the patient would be imperative. True, educating people on addiction doesn't always help, but we educate all day long. That's what we are, we're educators. Most just want your signature on a script, that's for sure. There's a conveyor belt of whether clinics or a private practice. Yes, that's true. You're welcome for the information on gabapentin. Mandatory reporter, how do you handle patients like the one with the children and DSF problems? I don't know how to answer that. I'm sorry. I have Baker-acted patients from my office. I have not called DCF. Karina, do you have more questions?
Right now, I do not see any more. Just a reminder to everyone to please put your questions in chat through host and presenter as your selection, or all panelists. Thank you.
Okay, so we're going to resume our little chat here. As you can see, we're open to questions. You can post them, and we'll get to them as best we can. So getting back to the underlying neurobiologic mechanism that explains the complex interaction between pain and opioid use disorder. In looking at the reward and emotion in chronic pain, you can see that these areas in the brain of pain and emotion and reward are all closely linked. And I like the slide on the right where the subacute pain is the gray and the chronic back pain is the black. And you can see that pain, when it's chronic, versus acute, you can see that acute pain is much higher than the pain of chronic pain. Yet the emotion of chronic pain is much higher than the emotion of acute pain. And the reward is high in both, but it's higher in chronic pain than in acute pain. So what the reward means is you want the pain to stop, or you want to feel the euphoric effects of the drug. They're both rewarding. In subacute pain, the reward is to make the pain stop, and in chronic pain, it may be a little bit more mixed.
We did have one question pop up. What can you do when someone is in active addiction and doesn't want help? Do you cut them off?
Well, I guess, I would ask you to clarify the question. If they're in active addiction and they're on the street behind a dumpster, we can't get to them if they're not showing up. But when they do show up and they don't want help, and I see a lot of this in the hospital, they show up altered, they show up overdosed, they show up having had CPR and they're intubated, and now it's on day 3 and they're now extubated and they just want to go back to their drug use. That's a case that I see a lot. So I see a lot of patients who are unwilling to address their addiction. They just come in, they want their antibiotics or they whatever acute medical treatment they needed. Like the lady, the slide I showed you, who she swallowed a fork. She didn't want treatment for her addiction. She wanted drugs, and she went so far as to harm herself, to require extensive abdominal surgery in order to get IV drugs. The way I handle that on the acute care side was with a little bit of motivational interviewing, and there are books on it, and there are courses you can take, and that's a skill that I continue to work on. I'll start out by asking somebody on a from 0 to 10, with 0 being not at all and 10 being 100% committed, how likely are you to stop or reduce your drug use? And only once has somebody ever said to me 0, like guaranteed 100%, I'm going back after the streets to use. I do not want any bit of what you have to say. I don't want any help. I have no intention of stopping. Usually people will give me a number somewhere more than 0. So even if it's as low as 3 on a scale from 0 to 10, when they're 10, I've hit my bottom. I'm ready to change. This is it. How can you help me? That's great. Those people are ready to change. But the people who give me a 2 or a 3, I then put them in the position to argue for the change. And what I mean by that is I'll say, so a 3, that's not bad. Tell me why you're a 3 and not a 2, or tell me why you're a 2 and not a 0. And as long as they give me some number better than 0, I've put them in the position to tell me what the benefits of change might be. And I've heard all kinds of things from, well, I could maybe get my kids back, or I'd be able to get a job, or I'd be able to have a relationship, or I'd be able to, whatever it might be. Getting them to argue for change is one of the first things I learned in motivational interviewing. So getting back to the person who doesn't want to change, I bet I can get a number out of them that's more than a 0. And I would start with that. And then on the more advanced side, on the hospital management side, what I do in many cases is I will start Suboxone in the hospital, which helps them not only with their withdrawal, which they're most likely having, but it also can help with their pain because it is a partial mu agonist. And we're going to talk a little bit more about that as we go on. So I hope I answered your question. I have a question. What are your thoughts about the explosion of chronic pain in the USA that has risen in sync with the rise of opioid prescriptions? Well, true. So if you have a hammer, everything looks like a nail. So people looking for opioids will suddenly find themselves with a chronic pain diagnosis so that they can come in and get opioids prescribed to them. Yes, I think it is definitely in sync. Getting back to our slide, neurocircuitry of substance use disorder. There are 3 stages of addiction that promote drug seeking. The binge intoxication stage, and that occurs in the basal ganglia, and that has effects of motivation for substance and through the dopamine and opioid peptides, and that also plays a key role in pain relief seeking, like we talked about on a previous slide with the relief reward from acute pain. The second stage of addiction is the withdrawal or the negative effects, and that takes place in the nucleus accumbens and the amygdala. And with a loss of reward and a withdrawal, people get the norepinephrine surges and they get dysphoria, they get increased pain and pretty severe anxiety. And the third state of addiction being preoccupation or cravings, that happens in the basolateral amygdala and in the hippocampus. And that involves a loss of executive functioning and a loss of good decision making. It includes impulsivity, compulsivity, and sleep disturbance. Considerations of pain and opioid use disorder is both substance use disorder and pain relief seeking behaviors activate and overstress the reward system. And when this is coupled with complex social, psychological, and biological stresses, certain people can be primed for the development of severe chronic complex pain and opioid use disorder. In both substance use disorder and pain, when the reward system is overactivated, the anti-reward neurotransmitters in the limbic system are enhanced, causing stress, negative affect, impulsivity, inducing compulsive behaviors to alleviate feeling lousy. And in both substance use disorder and chronic pain, the executive function of the prefrontal cortex is impaired, and they're unable to exert control over the ventral striatum and limbic system, which is the emotional reward system, and they prevent activities that promote recovery. So the brain's tricky. And I think all of that plays into the opioid-induced hyperalgesia that the attendee asked about. Which patients are most at risk to develop opioid use disorder? So this is a great question, and I've seen these numbers all over the map. The published rates of abuse and or addiction in chronic pain populations are anywhere from 4 to 26%, and I've seen it in some reports as low as 0.1%. So I think we don't know. But it suggests that there are known risk factors for opioid use disorder in the general population that could be good indicators for problematic prescription opioid use. And some of these include a lifetime history of substance use disorder, a past history of alcohol, tobacco, cocaine, or cannabis use, a family history of substance use disorder, a history of legal problems, heavy smoking, a history of severe depression, anxiety, or PTSD. So some of the questions I ask my patients, even my quick consults done in the ER, is I'll ask patients, have you ever been to jail? Have you ever had a DUI? Have you ever been in rehab or detox? Do you have any family members who have been in rehab or detox? And I think these are important questions. I also like to ask them financial questions, like how much a day are you spending on heroin? Because when it comes down the road of their pushback that they can't afford to be in treatment, why they can't afford to be in treatment, I'll go back to, well, you told me you were spending $80 a day on heroin. So I try to identify discrepancies, and that's also part of what I've learned in motivational interview. And I recommend you, if you, for the non-psychologists or even for the psychologists amongst us, there's more learning to do on motivational interviewing, and I think that's a fabulous newer science, and I love it. But asking these questions is very important, and or even as simple as, so back in the 2012s when we were seeing a whole bunch of the blues, the Roxys, the Oxys, and that's oxycodone 30 milligram immediate release, they just called them the blues or Roxys. I would ask patients, how do you take that? Do you swallow it, smoke it, snort it, inject it? And I've had nurses with literally their jaw drop because they've never heard somebody ask that question. And patients will say, if you ask, how do you take it? They may say, and I've heard this a lot, well, I crush them and snort them. They don't work if I eat them. And I thought it was fascinating, the questions we can ask and the answers we might get. But if you don't ask, have you ever used IV drugs in the past, they may not offer that up. So asking the questions is important. And it's interesting how I've walked out of a room and gotten so much more history than the primary care admitting doctor, who their report will say patient denied smoking, drinking, or recreational drug use.
Hey.
But yet I elicit the history, and it's simply because I asked. Most people won't volunteer that. Somebody's got their mic on. I don't know, Karina, if you can help that, but somebody has their mic on.
I think we're good now.
Okay. So what is opioid dependence versus opioid use disorder? Because opioid dependence, we understand and we've all been taught if you're on an opioid for a long period of time, your body will become dependent on it, and that is not the same as addiction. Dependence on opioid pain treatment is not, as we once believed, easily reversible. So we used to think that, yeah, it's just something that happens, something that the drug does to your body, and if you take it long enough, you'll be dependent, and so you could just wean it off, or we'll worry about that after your surgery, or we're not going to deal with that now, we'll deal with that once he's discharged from the hospital, or things I hear a lot. But it's not so easily reversible. Dependence is a complex physical and psychological state that may require therapy similar to addiction treatment. And whether or not it's called addiction, complex persistent opioid dependence is a serious consequence of long-term pain therapy. And I see this amongst all sorts of populations. I had a little lady say to me recently, well, of course I'm dependent on it. Of course I'm addicted. I mean, I didn't prescribe them to me. It's not my fault. I've taken them as prescribed. And I think she's 100% right. For the providers amongst us that routinely prescribe, 4 to 6 Percocet a day and think that that's okay, these people have a dependence, and now it becomes a deep psychological problem, and they have a form of opioid use disorder, and they require addiction treatment. So common considerations for pain management in the context of opioid use disorder is harm reduction. So somebody who, even let's say I have cancer patients who are IV drug addicts, it's probably not okay to give them a whole bunch of MS content and say, good luck with that, and I hope it helps your pain, because there's a really good chance that they're going to abuse it and potentially harm themselves. So how do we treat their pain and not put them in harm's way? So this has, the harm reduction has a root in public health. It does not specifically endorse illicit drug use, but it accepts it as a reality, and the idea is to minimize the harmful consequences. What's ideal? What's realistic? Well, harm reduction values life, choice, and respect and compassion over judgment, stigma, discrimination, and punishment. And I get all that, but when it comes down to what are you going to do? So what do I do when I've got somebody with metastatic brain lesions and they're actively abusing heroin? Those are the people I might either put on Suboxone, or I might put them on an extended release abuse deterrent opioid, such as Xtamza or Embeta, or one of the long-acting high-dose opioids that are more difficult to manipulate. They're more difficult to crush or snort. They're difficult to put in a syringe and inject because they deliberately are either mechanically or chemically designed to minimize either snorting or IV use of these drugs. So that's probably one of the 2 ways I would do it. If they need high-dose opioids, I would put them on an abuse deterrent, possibly even an intrathecal pump. And if their pain is not as severe as widespread bone mets, I might put them on Suboxone, which works very well for pain as well. Some people would put these patients on methadone for harm reduction, and I get that. What I don't like about methadone is I do see people overdosing and dying and shooting over it, whereas with Suboxone, it occupies the opioid receptors, so the word on the street and in general, you can't shoot over it, and it works fairly well for pain. I have a question here on the right that I kind of like. How many or what percentage of diagnosed chronic pain patients do you think are high-functioning addicts and physicians are actually medicating withdrawal pain and not the original pain complaint? I believe that you're right on, and I think that is widespread, and that's why I like to go out educating my pain physician peers on addiction, because most of them don't have any addiction experience, and they just believe their patients. And these are the doctors who think that their interventions, such as epidurals and surgeries and whatnot, are helping, when really it seems the game for the patient is they'll be compliant and do whatever the doctor says as long as they keep getting their medications refilled. Hope that answered your question. Opioid use disorder pain treatment general principles. Opioid withdrawal worsens other painful conditions. If you recall back on the description of opioid use disorder, on the description of withdrawal, one of the first symptoms is body aches and pains. So 100% opioid withdrawal makes the pain worse. And treating opioid withdrawal symptoms can improve pain. So I've mentioned to you several times that I use Suboxone for pain. Suboxone treats the withdrawal symptoms, but also as an opioid, it also improves their pain. Vivitrol would help their withdrawal symptoms and can help the pain of withdrawal, but wouldn't help their underlying pain. Giving opioids will not worsen a patient's addiction. Well, I don't know how I feel about that. I guess that's true. Giving IV pain meds to a heroin addict in the emergency room isn't going to worsen their addiction, but it's also not going to help their underlying problem. Patients who use heroin are highly tolerant to opioids. Very true. There's no getting a patient who's addicted to heroin. There's no getting that pain under control. When they have a serious trauma and they come in with IVDA and a fractured femur, that's not a patient who it's appropriate to withdraw opiates from. One, they're in withdrawal. Two, they're in significant pain. So that's somebody I would probably put on a PCA, which is patient-controlled analgesic, which is IV, usually dilaudid, and we can crank that up to high IV doses to properly treat that patient. Buprenorphine can effectively and safely be continued in the perioperative setting. That's very true, and I have some slides later on to show you the details of how that is best and most safely carried out. And multimodal treatment works best. So some considerations: if they're actively using, refer for addiction treatment if possible. Close collaboration with the prescribing facility is essential for patients with pain who also are enrolled in MAT maintenance programs. And maintenance medication is often dosed once a day and is not likely to manage pain in the acute setting. Pain management. So I mentioned multimodal analgesia is the best, and that includes non-opioid medications and, when possible, non-pharmacologic treatment, so, rest, ice, compression. And prescribe opioid therapy for pain only if you have experience or can collaborate with addiction medicine, which includes nursing and or social work support. They can be available to co-manage, and you have the ability to prescribe smaller amounts more frequently and manage these patients much more closely. So the Florida laws are a 3-day supply is appropriate for acute pain. So for patients who are admitted to the hospital with acute pain, I'll send them out with a prescription for 3 days, and they will follow up either in my office or with another provider in 3 days. Some considerations: universal precautions for opioid prescribing. Recognize fears that may arise in patients at risk for relapse, and those fears are both in the patients, in their family members, and amongst providers. And support patients by ensuring safe, appropriate pain management. It's scary for patients, like that example I gave you of a heroin addict, IV drug abuser who comes in and has a compound fracture of their femur and is about to go for surgery. They're terrified They're terrified that their pain won't be controlled because they know that their tolerance is so much higher. So it takes much higher doses to get their pain under control. Non-pharmacological strategies, when available, there's online pain self-management, CBT, mindfulness-oriented recovery enhancement, mindfulness meditation, combination of CBT and acceptance-based therapy, and there's just good old Lucy. I love that picture. In short, opioid reversal prescription. So this is naloxone, and naloxone rescue kits should be prescribed for all patients who are on high doses of opioids, which is generally thought to be anybody over than 50 milligram of morphine equivalents. And there are equivalency charts that you can look up if you're not sure what that means. But basically anybody on 3 Percocet 10s a day is on 30 milligrams, which is 45 morphine equivalent. So anything more than 3 Percocet a day would fall into this category of greater than 50 milligrams. Anybody at risk for overdose, because they may have organ dysfunction and their liver doesn't metabolize medication as well, because they're frail, because they have comorbid COPD or whatever else. If they're diagnosed with a substance use disorder and they're on MAT, or if they're in remission, not on MAT, or if they're actively using, and if there are safety risks in the home, so if there's another user in the home. So prescribing naloxone rescue kits, the bar is pretty low. We should be prescribing it more often than we are. Acute pain management strategies for opioid use disorder patients with active use. So utilize opioid-sparing medications. Consider initiation of MAT if the patient is willing to start. And there is no special waiver needed if the admission was not related to OUD. So for example, my femur fracture example, he has surgery, he's on the PCA for 2 days. On day 3, they switch him to Percocet. It's not strong enough, it doesn't work, he's in withdrawal now. That would be an okay time for even a non-waivered physician to start Suboxone in the hospital setting. IV PCA, I already mentioned that to you, may be the best option to determine dose needs or use scheduled meds instead of as-needed opioids. And what that means is you can determine their dose needs. You can expect that they're going to be high, and I mean higher dose needs, not high as in impaired. Their dose needs will be greater than expected for a patient without an addiction to heroin because of the tolerance they developed. But if you put that button in their hand and you set that to every 6 minutes that they can push the button and get 0.2 or 0.3 milligrams of Dilaudid, now they can get 3 milligrams an hour or 4 milligrams an hour. And if they fall asleep because the dose has gotten a little bit high, then they can't push the button. So the whole idea of the PCA is a built-in safety mechanism where if you're awake and you're in pain, you can push the button. And if you fall asleep or you get lethargic or your breathing slows down, you're not going to be awake enough to push the button again. So I look frequently at the pattern of use and how much they've actually pushed the button, and that can tell me what their dose needs are. And I find that works better than PRN meds, because then they have to use the call light in the middle of the night, call the nurse is in a more critical situation with another patient, finally gets to the call light, then they've got to go to the Pyxis or to the pharmacy to get the meds, and there's a delay. So PCA gives the patient better care. I call it Cadillac analgesia. Gives them better care. They have the button. They can push the button. They can use what they need, and we can have a good idea of what their actual dose needs are. And they can still have withdrawal symptoms even with treatment, and that's where clonidine or tizanidine may be helpful. Discharge planning with active OUD. Develop a safe discharge plan. Refer to outpatient treatment if the patient is willing to engage. If they're not and you've started MAT, inpatient will have to discontinue prior to discharge and try to avoid a gap in care. Prescribe naloxone for overdose prevention due to higher risk for overdose due to loss of tolerance. There's a question or a comment here I'd like to read to you. Haven't they found that Suboxone creates an actual neural break? I don't know why they'd even prescribe something like that. What are the most important risk factors that make it the best choice? Haven't they found Suboxone does not create a neural break. I don't know what that means. You don't know how they prescribe something like that. What are the most important risk factors that make it the best choice? In the example I'm giving you, when I start Suboxone in the hospital on somebody who is actively using IV heroin, giving them Suboxone stops the withdrawal. It reduces their cravings. And I find after a patient is on 2 or 3 days of Suboxone in the hospital, they say to me something like this: "Wow, doc, I feel great. Thanks for sticking with me. I'm sorry I was such a nasty person to you," but they use, of course, more colorful words. "I am so glad you stuck with me, and I can't believe how good I feel, and I think I can do this." Suboxone has been a game changer in so many people's lives. I'm not familiar with this attendee that makes the comment about it causing a neural break. I don't know what you mean by that. You can write in again if you like. And you don't know why they would prescribe something like that. We prescribe something like that precisely because it helps with withdrawal symptoms immensely, and it gives them an opportunity to experience what life would be like off of the IV heroin and onto medication-assisted treatment with Suboxone. It's been incredibly successful. It's a partial mu opioid agonist. It occupies the mu receptors. Chronic pain management strategies. So this is now on the chronic side. This is more the people I see in my office, and they have active opioid use disorder. Again, utilize non-opioid analgesics or multimodal analgesia. Opioids may not be a consideration unless it's serious illness or end of life. So like I said to you earlier, I might prescribe high-dose opioids in my cancer patients, in my end-of-life patients, in my serious illness patients. If opioids are necessary, consider frequent visits, dispensing small amounts of medications, frequent urine toxicology screens, enlist the help of friends and family, and assess their home situation. Is it safe? Acute pain management for individuals on MAT. So the methadone, Suboxone, and naltrexone. Methadone is a full mu agonist. Suboxone is a partial mu agonist, and naltrexone is a full mu antagonist. The doses are there. Where it's obtained, the methadone has to go through a methadone program, which is generally daily doses. They can graduate to take-home doses, and in the midst of COVID, these people are getting 2-week take-home doses. Suboxone can be prescribed by physicians, nurse practitioners, and PAs in an outpatient center if they've had their waiver, and it can be found at some outpatient treatment programs. Naltrexone is an injection administered by any clinician who is a prescriber. And some of the comments about methadone, Suboxone, and naltrexone. Methadone provides analgesia for basically 8 hours, so more than once daily dosing is necessary for pain. And there are many drug-drug interactions, and it can cause QT prolongation. Suboxone can provide analgesia for generally 8 to 12 hours, so usually they give it twice a day or 3 times a day. If pure mu opioids are needed in the short term, they must be given at higher doses, and we'll talk about that a little bit later in this program about what happens when somebody on Suboxone comes in for surgery, elective surgery or immersion surgery. There are also buprenorphine implants that are put in the arm. They can be removed prior to 6 months, and Suboxone has fewer drug-drug interactions than methadone. Naltrexone is also used for alcohol use disorder, and it blocks the effects of opioids because it is a full mu antagonist. So it's not a good choice for people with pain requiring opioid therapy. There's a comment here: I feel Suboxone can be abused. I know it has potential for diversion, but back on abuse, every patient has a turning point where they don't want more since the lack of euphoria. What do you think? Suboxone can be abused and can be diverted, and that's why they still have the limits on prescribing. and they're monitoring that very closely. My feeling is, yes, many substances can be abused. I mentioned earlier, even Neurontin is abused. Lots of medications are abused. I think Suboxone in the hands of an abuser and diverter is safer than the full agonist opioids. So, yeah, getting back to the harm reduction model, I feel okay prescribing Suboxone and keeping a close eye on patients to make sure that we're doing our best to minimize diversion. It's impossible to prevent diversion or abuse. Acute pain management and MAT evidence. There are no prospective design studies. Their evidence is based on limited controlled retrospective studies and case series, and I have thousands of retrospective studies in my own practice. Findings are continuation of methadone and buprenorphine during acute pain events is feasible. Discontinuing naltrexone, because like I said, that's antagonist to the mu opioid receptors. Higher doses of opioids may be necessary in this population, and use of multimodal analgesia is recommended, but reported use is inconsistent. Methadone for acute pain. Most facilities, my hospitals, have their own institutional policy. But if you cannot verify the methadone dose because it's a night or a weekend, then in general you can prescribe up to 40 milligrams daily, which is best in divided doses, or whatever your institutional policy might be. Other options for acute pain management with methadone only would include adding additional doses of methadone to provide pain management, so whatever their baseline is, to give them more. For example, you might give an extra 10 milligrams in the afternoon and evening, and clearly document on that prescription or on your chart that this is for pain management. If you cannot use oral, utilize methadone IV at 50% of the oral dose. And you can utilize methadone in split dosing as often as QID, but clearly document and discuss it with the OTP. Again, methadone for pain lasts about 8 hours. So if you're dosing it once a day, if they're taking 140 milligrams of methadone at the clinic every day and now they come in with acute pain, you may want to take that same dose and split it TID. It'll work better for their pain, or they may need additional. Methadone for perioperative pain. Continue methadone for opioid maintenance if possible. That may need to be held in cases of hemodynamic instability. Utilize multimodal analgesia, including regional anesthesia. That's always a great conversation to have with the anesthesiologist or the surgeon. Perhaps there's a nerve block that can be done, or an epidural to prevent postoperative pain. And the hip surgeons have gotten really good at that. They do the femoral blocks, and then they get great, or the Exparel, the long-acting injectable local anesthetic. If utilizing opioids, utilize the least amount and the lowest dose while maintaining analgesia. However, they may need higher doses than those without OUD. Consider EKGs, especially on the methadone patients with QT prolongation, or if using QT prolonging additional medications. Arrange for discharge plan if prescribing opioids for discharge. So that may need to be communicated with the OTP if they're going to a methadone clinic and you want to give them Percocet for discharge. You're going to need to make the OTP aware. Prescribe naloxone for overdose prevention. Ensure education on tapering opioids post-discharge. Buprenorphine for acute pain. The mu receptors are occupied but not fully activated with buprenorphine, and that's why they call it a partial mu agonist. If patients require opioids for pain, they will require higher doses of their opioids to overcome the occupied mu receptors. And if buprenorphine is discontinued, it takes about 72 hours to dissociate the buprenorphine from the mu receptors. So if the plan is to discontinue the buprenorphine for elective scheduled surgery, you would want to do that 3 days ahead of time. If the patient does not discontinue it, or if the plan is not to discontinue it, or they come in for emergency surgery, just understand that they will require higher doses of pure mu agonists to overcome the occupied mu receptors, that is the buprenorphine on board. Buprenorphine options. If the patient is admitted on buprenorphine with pain crisis trauma surgery, there are no consensus guidelines, but I see this a lot. So generally, you can continue the buprenorphine, you can increase the dose, use multimodal analgesia, you can continue the buprenorphine, you can wean the buprenorphine and treat with multimodal analgesia and use short-acting higher dose mu agonists, or you can wean or discontinue the buprenorphine prior to surgery and use multimodal analgesia and mu opioid agonists to treat pain, and you can restart the buprenorphine after the acute pain resolves. So in the IV drug addict heroin user with the femoral fracture in the example that I gave you who had surgery, was on a PCA for a couple days, usually after that I might put them back on Suboxone, or like I think I said, the surgeon may put them on Percocet. It's not strong enough. I'm not going to be comfortable sending somebody home with very high doses of short-acting opioids. So I think that patient would be safer probably on Suboxone. Continue buprenorphine therapy and consider divided doses every 6 to 8 hours and can increase the dose to a maximum of 32 milligrams daily. So if somebody comes in on Suboxone, buprenorphine, they're taking 8 milligrams twice a day, I might step them up to 3 times a day or even 4 times a day up to 32 milligrams. Utilize multimodal analgesia. Treat acute pain with mu opioid agonists such as fentanyl, hydromorphone, morphine, oxymorphone, hydrocodone, oxycodone, or a sublingual or IV buprenorphine if available. Ensure monitoring for respiratory depression. You can override the mu receptors with higher doses of opioids. And that's something I probably say once or twice a week to an anesthesiologist. Don't worry about the Suboxone. You can still give them the IV fentanyl in the OR. It's okay. You can override the mu receptors with higher doses of opioids. What I mean by that is it's not an all or none. Some anesthesiologists have said to me, well, I can't even give them any fentanyl because it's not going to work because they took Suboxone this morning. Like, no, it's not all or none. You can override the mu receptors with higher doses of opioids. It's discontinuing buprenorphine. You may consider discontinuing on the day of surgery, and it may require high doses of opioid to overcome the buprenorphine. But if you wean over 3 to 5 days, if the pain is intolerable or the withdrawal is intolerable, you might use methadone, or you might use immediate release or extended release opioids prior to admission. And if the pain resolves, you can allow for mild withdrawal and then resume buprenorphine. But in each case, you have to weigh the risks and benefits for discontinuing buprenorphine. And the higher the risk for overdose if discharged without restarting buprenorphine. So if my patients have a real high risk of overdose upon discharge, I will make it my business to get them restarted on Suboxone before they leave. Naltrexone, if they have naltrexone on board and they come in with acute pain, that's tricky because naltrexone, as you know, is an antagonist at the mu receptors. So if you have some time for scheduled surgery, you'd want to discontinue the IM naltrexone a month before surgery, or discontinue the oral naltrexone 3 days prior to planned surgery. In the event of a trauma or acute pain or unplanned surgery, you may need to use much higher doses of full-on agonists, opioid agonists to obtain efficacy. You might need to use 20 times the usual dose. So you would want to closely monitor that patient in the PACU and post-op, depending on how high doses of opioids they are receiving. They might even need an ICU bed if they're going to be on like a morphine drip to manage their pain. I've seen some frightening cases. Use multimodal analgesia to maximize analgesia without the use of opioids. Do not restart naltrexone until 10 days after the last opioid use, because the last thing you'd want to do is take this patient that you've worked so hard to gain control over and now give them an IM shot of naltrexone and put them to full-on withdrawal. Discharge planning includes plan for restarting naltrexone when it's appropriate, a safety plan for administration, tapering, storage, and disposal if discharged with opioids, naloxone for opioid reversal, and education about the increased risk for overdose due to decreased tolerance. And what that means is if they've been now off opioids or on a lower dose of opioids for some time during a lengthy hospitalization, if they go out and use their previous dose that they thought they had gained a tolerance to, that tolerance gained is now potentially gone and they could have a fatal event. I have a question here. During the COVID-19 public health crisis, some states, New Jersey, for example, have had their regulatory boards require the co-prescribing of naloxone with opioids. Do you see any movement by the Florida boards for co-prescribing of naloxone? It's already recommended by the CDC. So I am making a point of prescribing naloxone. It's recommended. I think it's a good idea. I don't think that Florida is blatantly requiring it. I could be wrong on that, but it should be standard of care. And for any of your patients, the slide earlier, if you recall, anybody over 50 milligram equivalents of morphine should be prescribed naloxone. Chronic pain management strategies for those on MAT utilize multimodal analgesia. Opioid therapy should be used only in cases of unresolved pain due to trauma, surgery, or injury, progressive disease, and end of life. Ensure use of universal precautions for opioid prescribing, such as treatment agreements, urine drug screens, prescription drug monitoring program checks, frequent follow-up and reassessment, communication with the prescriber of MAT, pill counts, use non-pharmacologic measures if available, and always ensure there's a prescription for naloxone for opioid reversal. Methadone for OUD and pain. Collaborate with the opioid treatment program, as only these programs can prescribe methadone for opioid use disorder. If they have pain and they don't have opioid use disorder, then pain prescribers can prescribe methadone, but we're talking here about methadone for patients with OUD and pain. So when my patients say I go to the clinic on methadone for pain, I say, you're not at the clinic for pain because the clinic doesn't treat pain. The clinic treats opioid use disorder, and then they may give me the history of drug use, which they may have denied previously. So only the OTP can prescribe methadone for OUD, and if an individual continues with the OTP, there's some evidence for better analgesia using methadone, breaking it up in the morning and evening. But if you're going to do that for pain management, you have to clearly document that on the prescription and in the chart that this is being used for pain, not for OUD. And you can use other additional opioids in addition to methadone. You can use other opioids if additional methadone is contraindicated, such as they have prolonged QTC. But be careful about other opioids not to trigger a craving. And as I said earlier, I know a lot of people on methadone who will abuse opioids and using the methadone just as their baseline not to have significant withdrawal, but they still abuse opioids. Unlike with Suboxone or buprenorphine, it's harder to use opioids and get the euphoric result that they're looking for. Buprenorphine for OUD and pain. Obtain the waiver to prescribe buprenorphine naloxone for opioid use disorder. Split doses of buprenorphine naloxone for pain management. Utilize up to 24 milligrams daily. Generally, insurance approval becomes problematic at doses greater than 24 milligrams daily, and there's no significant evidence for increased efficacy. So I'll go up to 32 milligrams in the hospital, but I don't have anybody in my office on 4 a day. They're usually at 8 milligrams BID. Generally, do not use mu opioids with buprenorphine unless the patient is hospitalized with acute pain. Question, how comfortable do you feel prescribing above 24 milligrams? Like I just said, I'll use it in the hospital setting, but 3 a day is unusual in my outpatient practice. Most people I have on 16 milligrams. Naltrexone for OUD and pain. So low-dose naltrexone is interesting also, but utilize multimodal analgesia without opioids. If opioids are required, collaborate with addiction specialists to rotate to an agonist therapy and educate on risk for accidental overdose if relapsed during a transition. So when you finally get the patient who's on naltrexone off of naltrexone, the transition to full-on opioids can be a problem because their tolerance to their previous opioid use has gotten much lower during this holiday. Acute and chronic pain management strategies for those in remission, not on MAT. Multimodal approach, including non-pharmacologic strategies. So, for example, the OUD patient in full remission comes in for elective knee surgery, doesn't want opiates. So a good block, good regional anesthesia would be important, all the other non-pharmacological strategies. Continue or engage in psychosocial programs, offer non-pharmacological strategies if available, and naloxone for opioid reversal, even if not on opioids, due to their risk of relapse. Safety measures. Random urine toxicology screening. Requests for authorization or release of information to obtain corroborating information and engage with patient's family. Prescription drug monitoring program check in Florida, that's the E-Force. Referral for psychiatric evaluation consult, random pill counts, review of medical records. These are things I do every day. And except for pill counts, I do almost all of that in the hospital every day. So I get drug screens on any patient that I am suspicious of for whatever reason. I have patients who will refuse to release information. I have patients who will refuse drug tests. I have patients in the hospital who will refuse testing. So recently I had a patient who insisted that they were on, I think, Subsys and fentanyl and Actique for metastatic pain. And on her E-Force, she had very high doses, high frequencies from multiple doctors all over the place, all short supplies, like 2 to 3 days leaving the hospital, but a lot of pills. And I forget exactly what her E-Force said, but she hops from hospital to hospital to hospital, and she would say, you can't talk to my family. She would put nobody on her HIPAA form, and she didn't have any documentation. She insisted she had cancer, but refused all kinds of testing. Wouldn't get a CAT scan, wouldn't get an X-ray, wouldn't do anything. And it took me a little bit, but I finally figured out that she was faking her cancer. She would just come into the hospital to get more drugs, and she just wore out the providers taking care of her. So I not only do tox screening, but I request authorization. I'll try to get old records. I'll try to get permission to talk to the family. I do the E-Force check. I often get psych consults and pill counts, but I will also do things like restrict visitors if I'm concerned that somebody will bring them in substances. I'll do contraband search in the hospital. That's as simple as putting an order in the chart to call security to come do a contraband search, and they'll go through the patient's belongings. I'll restrict visitors because I've had visitors bring in, syringes and paraphernalia in the McDonald's bags. I had a 5-year-old girl once bring mommy in her heroin. It's so sad. And ironically enough, in the midst of this COVID epidemic, I'm not having to do that because once they send their belongings downstairs, nobody's bringing them in drugs. So that's been sort of the silver lining in safety for these people in the hospital now. And some patients are actually very relieved when you restrict visitors because they can't control it. So, for example, I've had patients that are victims of human trafficking. I've had, prostitutes who their handlers will come in and, take care of them however they want to take care of them. So there's so much more going on than we can possibly address in the limited arena of a hospital visit. But there's so much more that we can do than we've done in the past. But I think earlier came up, what do you do if somebody doesn't want to change, or how do you address resistance? And by the way, not only in the substance use disorder patient, but in the staff taking care of the patient, because a lot of the staff taking care of these patients, and this is true of nurses, PCAs, physicians, administrators, just kind of eye roll about these people, the frequent flyers and the drug seekers. And if we can treat these people appropriately, we can get so much more for them by being fair, firm, and consistent, by avoiding staff splitting. So when I say no to IV Dilaudid on a patient, and then the patient complains to their admitting doctor, and the admitting doctor then lets the patient fire me and then goes and orders the IV Dilaudid, that doesn't help the situation in the bigger picture. So fair, firm, and consistent. Shift change reporting. I had a nurse recently that I asked her to get a urine drug screen on this patient, and she didn't feel comfortable asking the patient a second time because her family was there and yada, yada. And this was a girl who was actively abusing IV drugs, but she didn't want her family to know, so there was a whole HIPAA thing. And she wouldn't give the urine sample, and the family didn't know that she was using drugs. So there were all these secrets around. So I had wanted to start her on Suboxone. I had eventually ended up getting her on Suboxone, and that's a story for when we have more time. But the nurse actually in that case was the obstacle of, I don't feel comfortable asking her for a urine sample in front of her parents because I know she doesn't want to give it. And I'm like, well, ask in front of her parents and let her parents ask her why she won't give it, because asking for a urine sample is not violating HIPAA. It's not giving any results or any reports. It's just our standard. Better communication between staff and specialists. This is where I spend my life, is trying to communicate between the nurses and the other specialists and the primary cares and the ER doctors. So the staff working together for a common patient goal. Engagement of family and support system, engagement of the current treatment provider, such as a therapist and the treatment center. Getting some comments here. Yes, you have to take extra measures to ensure that people drug seeking at hospitals are not getting medications and are not sick, but we should be able to link them with or refer them for treatment. True. You have to ask the tough questions, as that may be the catalyst to the person getting help. True. I love all these comments. Yes, I think in the hospital we have a responsibility to do better, because sometimes they're getting sick, and I've seen people shoot up and die in the hospital, in their own hospital beds, in their own bathrooms, and it's really sad. So getting back to our case study, the thought questions. Does this patient have pain? Yes. Does this patient have an opioid use disorder? I think most of you said yes. What factors put this patient at risk for an opioid use disorder? All of them. Personality traits, the young age of opioid initiation. Remember, she started when she first had her baby. Concomitant use of benzos, which she was on. Mental illness, placing greater vulnerability for chemical coping. She had, remember, depression and anxiety. Adverse childhood experiences, history of medication non-adherence. She had lost prescriptions, possibly compulsive use of the medication. She had possible frequent bouts of opioid withdrawal from overuse of opioids, causing the withdrawal, and which would affect her motivation and craving. So she had all of those things. So the patient undergoes a full opioid use disorder assessment, and it is determined that she has a moderate opioid use disorder based on her failure to fulfill roles, her continued use despite harm, her time spent procuring medication, and craving. She is reluctant and scared to consider alternative treatments or seek opioid use disorder treatment, but is appreciative of the honest assessment of her condition. She would like to think about the idea. So this speaks back to motivational interview. She's ready. We're assessing her readiness. She has some reasons to think about change. She's probably in the pre-contemplative stage. And remember, the moderate opioid use disorder, that was based on the 2 to 3 symptoms in each of the 4 categories. 2 weeks later, she makes an appointment to see you, and she seeks treatment for her OUD. 3 months after stabilizing and starting Suboxone along with CBT, she says, "Thank you so much for helping me. I am myself again. I am finally enjoying my life with my kids, and I'm thinking about starting a small business." Fabulous outcome. And this happens all the time, and more of this should be happening. Not enough people are being offered MAT. There's a comment here, I've seen staff splitting, and there needs to be a clear message to all staff, including admitting physicians, nurses, and even down to the admissions discharging staff, that if someone suspects drug use, they must follow procedure for testing and asking tough questions. Right on. I agree with you. Are there any more questions? We've finished with 10 minutes to go, which is good timing. We've got time for some questions. It is very concerning that our ER departments in South Florida continue to dismiss patient overdoses and patients seeking help. How can we engage the medical community better? Great question. Can anybody else answer that? Because I spend my life trying to engage the medical community better. I think through educating, through awareness, I think through great results, I try to show them our own successes, because I do sometimes get called for consults in the ER, and I like to revisit the ER to give them the feedback on how well that patient did. Somebody commented here, in my region, DCF, we're advocating for the use of naloxone and utilizing our state-funded program for take-home doses to the client and their family. That's great. I see a lot of that, but starting on naloxone or naltrexone is not appropriate for everybody. I mean, it's important to have that in the home when they're at risk, but starting MAT and Suboxone in particular is much trickier and much safer and more long-term benefit for the patient. Another question, do pregnant females need high-dose buprenorphine as pregnancy goes on? I've seen that. In fact, I had a pregnant woman I saw this morning. Actually, she gave birth yesterday. First time I met her was this morning postpartum, and I started her on Subutex last night. She was escalating her heroin use during her pregnancy, and my thought on that is perhaps as their volumes increase and their cardiac output increases, they might be chewing up medications faster. So I think that that's likely, and that's probably why her heroin use escalated. She tried to stop using heroin a few days ago, went into labor, and had the baby yesterday. And she's on Subutex now, doing really well. And also, just to be clear, in pregnancy and postpartum, we use Subutex, not Suboxone. Another question, I've seen that having engagement with the medical community by having community meetings and a discussion panel for education and training does seem to be helpful. Me too. I've done many town hall meetings, and I'm always available and always looking for opportunity to educate more. I have tremendous experience in this space for over 25 years treating opioid use disorder before we knew it was opioid use disorder. Another comment, I'm so grateful for this. Oh, thank you. I don't think that folks realize that people get sick and injured while on drugs and go untreated. Thus are not just drug seeking. Right. If we teach them overall wellness as a recovery goal, it helps clients and staff to participate without the usual drug seeking mentality on both sides. Agreed. Another comment, more education between agencies. I have clients threatened with not reuniting with their children if they do not discontinue Suboxone therapy. That is horrifying. I'm going to read that again. More education between agencies. I have clients threatened with not reuniting with their children if they did not discontinue Suboxone therapy. Again, horrible, 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 horrible. I haven't heard that. Somebody please help with that. Let me know more about that. Fix that. Another comment, I am a peer support specialist in local ERs near Jacksonville. When people come in as an overdose or a substance abuse illness, we go in and try to get them into detoxic treatment. A problem I run into is the negative attitudes of medical staff towards patients with SUD. You're right. You're right. You're right. You're right.
We had a question about your thoughts on the use of Vivitrol.
I think it's very useful for alcohol use disorder. I think I haven't used it for opioid use disorder, but I think it would be helpful. Most of the patients, frankly, that I meet with opioid use disorder also have pain because I'm a pain specialist. So I don't work in an addiction treatment center. I work in hospitals and in my outpatient pain management clinic. So that's probably my user bias.
We also had a question, how is her increase in opioid use affect the baby?
In the pregnant lady, the baby this morning, I think you're talking about her increased heroin use.
Yes.
Well, for neonatal withdrawal syndrome, the higher the opioid use, the worse withdrawal the baby will have. In her case, she stopped using heroin to hope. I think her thought was, I have to finally stop because I'm going to give birth and I don't want my baby to be sick. Maybe that's what she thought, or she didn't want to get caught, or she didn't want to lose the baby. But she tried to do the right thing by stopping her heroin use, which probably increased her blood pressure, which probably made her restless and probably brought on labor earlier than expected. And the baby is now doing horribly. The baby was born with thick meconium, aspirated, is intubated, and they say has a 50-50 chance of surviving. And she's devastated. And also just last week is when her husband found out that she was using. So there's a comment about the kids that I want to share with you. If that is happening, you're threatening to take the children away if they did not discontinue Suboxone therapy. If that is happening, then it needs to be reported. We have done education with child welfare cases. However, I know that we can do better. And there's a contact. They can contact me. There's Nikisha Phillips is offering her help. Nikisha Phillips at myfloridafamilies.com.
And I just shared that email with the group.
Thank you. Wouldn't that be great if we can do some good out of this presentation? Thank you.
We also had another question about your thoughts on medical marijuana.
Briefly, I think that it can be helpful in certain populations. I think the science is a little wonky on that, but I'm willing to use it in certain circumstances. I am a medical marijuana recommender. I have seen some success with it. I do believe it's opioid sparing, and I'm willing to help patients who need help.
We have another minute or so. If you have any questions, go ahead and ask them, please.
There's a statement here. It was reported, and I believe DCF has now mandated that CPIs can no longer threaten clients with their MAT. Thank God. I thank you so much. We've got just a couple minutes left. I'll take any questions that do come up in the next minute or so, but I want to thank you for your time and for your attention and for hanging in there. I know 2 hours is a long time to sit. This is really important information, and I think we need to do more of this. And you keep on doing your best and helping these people. Thank you so much. Some more questions, comments. A lot of clients are experiencing kratom. What are your views? I hate kratom. I have no idea. I just see bad experiences on patients with kratom. I've heard some stories that it can help people get off drugs. I haven't seen that. I don't believe it. Great presentation. Thank you. Thank you. Thank you. Glad you all enjoyed it. A lot of really positive comments. I thank you all for the warm, great comments, great feedback. Keep fighting the fight. I'm going to go back out and help some more people.
And we also want to thank you, Dr. Rosenblatt, for your wonderful presentation. You answered a lot of questions that we had out there and gave a great wealth of knowledge to us. And so we thank you again. And for our audience, if you could just stay on for a couple more minutes so I can give you some housekeeping information regarding CEUs. When I conclude today's webinar, your browser is going to take you to an evaluation on our FADA website. If you want to receive CE credits or a statement of credit for this event, you must complete the evaluation. You will be prompted to register or sign in to complete the evaluation, and just want to let you know that although you've registered for the event, you must also complete a profile on our FADA website. So you have to do both. And you can register as a visitor at no cost. For CEs to be reported to CE Broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you will be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up your profile in FADA system. This helps us connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today in about 30 minutes. The sender will be Messenger at WebEx. Just please note that the evaluation closes in 2 days, well, 2 business days. That'll be midnight on Monday, May the 8th. I do want to also mention that the statement of credits and CEUs does take some time to process, so once you complete the evaluation, it is not immediate that you receive your credit. It can take up to 30 days. We try to get them in sooner, but it's usually up to 30 days. We do not email the statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. We want to thank you for participating in today's webinar, and we'd also like to recognize and thank especially the Office of the State Courts Administrator for funding today's education. Have a great rest of your day, and please hold for the evaluation.